Hi, everybody. It is 12 noon, so we'll go ahead and get started. Welcome to the American Heart Association's Get With the Guidelines Coronary Artery Disease webinar. This is the third and last webinar in a three-part series. Before we get started, we would like to go over a few housekeeping items. To avoid background noise, all lines have been placed on mute. To ask questions, you can unmute your lines by pressing *6 or type in the Q&A section of WebEx. All slides and handouts will be sent to the attendees within a week of the call. Please also visit www.heart.org/SWA Quality to view the recording of today's webinar. I am pleased to announce that Kristen Waller and Cherie Boxberger will be leading today's webinar. Cherie has a master's in exercise physiology, an MBA, and is a certified professional in healthcare quality. She has been with the AHA since 2009. Prior to moving to Texas and the Southwest affiliate in 2013, her responsibilities included working on STEMI systems of care in Missouri, Kansas, and Nebraska. Her work in unfunded statewide projects brings hospitals of all sizes together to pursue improved survival with an emphasis on the needs of the critical access in small community hospitals. Our second presenter, Kristen Waller, is the Director of Quality and Systems Improvement for the American Heart Association for the state of Arkansas. Before joining the AHA, Kristen was the STEMI and Chest Pain Center Coordinator at a STEMI receiving hospital. She is a nurse and an experienced data abstractor, having abstracted for the NCDR Action Registry in her previous role. I will now turn the webinar over to Cherie.
Well, hello, everyone, and we are so excited, both Kristen and I, to be able to talk to you about Get With the Guidelines, coronary artery disease, as well as some issues around the elements that we measure for the referring hospital. We spend an awful lot of time talking about what we do for our bigger receiving hospitals, so I'm just super excited for us to have a session that's really focused on our referring facilities. Because not all of you may be familiar with the products that we bring in the suite of quality initiatives, we do have Get With the Guideline programs across several diagnosis areas, including stroke to heart failure, atrial fibrillation, code blue, or what we call resuscitation, as well as a number of emphasis programs like Target Stroke, where the emphasis is door to needle for our acute ischemic strokes. And these programs came about when in the early 2000s, our physician leadership realized that we were doing so much work and so much research, but we were having difficulty bringing changes in the guidelines to the actual bedside. And so it was at that time that they created Get With the Guidelines, this series of quality programs, which did include coronary artery disease. So, in this country, nearly half of the nation's hospitals participate in at least one Get With the Guidelines quality improvement module. Over 6 million patients have been treated at Get With the Guidelines participating hospitals, and 80% of the U.S. population has access to a Get With the Guidelines participating hospital. I will say, however, that the folks that don't have access to a Get With the Guidelines participating hospital are primarily those who are in those less populated areas where there aren't as many hospitals, or where the majority of the hospitals are small, either critical access or community hospitals. And so, of course, that is our focus here today, is to talk about that size of facility. First, a couple of definitions, because we'll be, it's healthcare and we like to use so many acronyms. So you'll hear us talk about GWT GCAD, or that's Get With the Guidelines, coronary artery disease. And this is a quality improvement product that has a supporting registry to support not only AMI, but also coronary artery disease that is not acute, as well as chest pain quality management activities. You'll also hear us talk about Mission Lifeline. And this is our 10th year of doing Mission Lifeline. And Mission Lifeline, if you think about, I think I've got a good slide here, if you think about the emphasis we had for the last 20 years or so on door to balloon. The concept with Door to Balloon is a quality improvement program, a very important one, where we're really talking about, are we being as efficient as we can from the time a patient arrives at our receiving center to the time that that vessel is open, or to reperfusion, or we call it balloon. And while that has been a very important initiative, you who are parts of smaller hospitals understand that there's a lot of time that takes place before you get to that cath lab facility or that PCI center. So we not only have the patient making the decision that they know their signs and symptoms and that they're going to call 911, or in smaller communities, and I'm from one of these, they're going to drive themselves to the hospital or have their loved one drive them. There's also possibly a community EMS taking them to the small or referring hospital. That hospital has to do the work that they do. They also have to arrange, in many cases, a transfer for that patient to a receiving center. So as you can see, Door to Balloon ends up being a tiny element, and that whole continuum is what we call Mission Lifeline, and that's working with all the parties, and as you see on the slide, the EMS providers, the referral hospitals, as well as the receiving hospitals, to optimize the care for a region or a state or a county, that kind of thing. Now, this is Mineola District Hospital. This is my stomping grounds. I come from western Kansas, a 600-person town, and so this is a critical access hospital for that part of Kansas. Actually, my grandfather was on the board for this hospital when it was built, and believe it or not, after they got it open, his daughter, my mother, was the first patient who actually had sleeping sickness and was admitted there in 1956. Full disclosure, this hospital has actually been torn down, and they have a beautiful new 15-bed facility there serving Clark County, Kansas. So this is why I have the passion I have for making sure that no matter what size of facility you are, that you have the tools to be able to do the best. And Get With the Guidelines, coronary artery disease, this registry is a low-cost way for you in the smaller communities to set yourself apart. It allows you to be able to be recognized, to demonstrate that you are providing the highest quality care, and to tell you the truth, it keeps your patients that live in your catchment area from always choosing to go further, and in many times with these time-critical diagnoses, negatively impacting their care. So when you choose to participate in Mission Lifeline, you participate as a receiving center, one who has 24-hour PCI, as a referring center, and we do have some referring centers who have cath labs. They just aren't running them 24/7. Or you might join us as a part of EMS, because EMS can also be recognized for their performance. In the registry, where the STEMIs, NSTEMIs, and chest pain patients are documented, you can then run what we call Mission Lifeline Receiving Center reports. Those are for our bigger hospitals, so that they can see what's happening in the continuum of that care, all the way from first medical contact to reperfusion. You can get reports for yourself. I know many of you on the call are from smaller facilities, or you're from bigger facilities and you want to support your referring facilities. There's specialized reports just for your size, so that you can see, am I doing the things that I'm supposed to do, the type of hospital that doesn't have a cath lab. And then the neat part of this in Mission Lifeline is that over the years, we've been able to have regional reports which say, how are we doing as a county? How are we doing as a RAC? How are we doing as a state? And those are part of that, as well as the ability for, if you meet our guidelines, which we'll talk about, to be able to get bronze, silver, and gold recognition that you're doing your very best in those areas. And just an update, although we probably have smaller facilities, just so that you're aware, after the first of the year in 2018, the data, the 23 or so data elements for chest pain accreditation will be included inside of the Get With the Guidelines coronary artery disease program. The things that you've been entering in ACD, you'll be able to combine those into one module should you choose to move forward with Get With the Guidelines coronary artery disease. All right, let's jump in and talk about what the referring center treatment guidelines are. So for a STEMI, and we're going to talk about ST elevation here. I do address NSTEMI a little later. STEMI referring centers, really the trick here is ECG within 10 minutes of arrival, and that's not 10 minutes of coming to the desk. That's 10 minutes from actually entering the facility. So you know how quickly this time can get away, and we're going to talk about each of these a little more in depth, but let's go through the list. If the patient is eligible and you're unable to get them transferred in a certain amount of time, we do have a requirement of door to needle or arrival to thrombolytics in 30 minutes. The third one, so critical, and I know those of you who are on the phone with PCI centers, really working with small facilities to make arrival to the actual transfer that's out the door within 45 minutes. That really takes a lot of coordination to be able to make that happen. And of course, ask-centered arrival. And then for the ST elevation patients who would be discharged from your facilities, which many of these would not apply since you're going to be transferring them out, aspirin, beta blocker, statin, and of course, smoking cessation. So let's talk about each of these a little bit. ECG within 10 minutes of patient arrival. And as this says, it is first things first. This is particularly important for those of you in smaller facilities. I'm from a farming community, and a high percentage of smaller communities, the patients will choose to either transport themselves either in from farms or to come on their own and not call 911. The situation in my hometown is it's volunteer EMT. So when you call the ambulance, we have to gather those individuals from the community so that they can come to the ambulance, and they do a wonderful job. There are no paramedics in that setting of my hometown. So when those patients either walk in, you're not going to have any sort of an EKG that's been done either on the ambulance or in advance. So you must get that. There's several parts of this. Who should get it? Who's trained to do it? Do you have the equipment? And then what to repeat. Now, what you're seeing here is a guideline that we've put together that many of our Mission Lifeline regions will use. Some of you participate in RACs, and you perhaps have a different one, or your medical lead has done something slightly different, but this is one that you could start with and tweak it for your benefit. So as you see on the list, the patients that should have a 12-lead ECG and or be triaged immediately, and you have to really be aware at the front end for those walk-ins, is you see it here, chest pain obviously or persistent discomfort above the waist. We're using that kind of above the belly button mechanism to determine this. Always be thinking about those patients who might not present in a traditional fashion, particularly women tend to have different symptoms. You can see it. I'm not going to read it to you, but as you look down there, be aware if you've heard of any history as it relates to cocaine or illicit drug use. That's something that might kind of mask a heart attack while it might be a younger person. Look at the bottom there. It says, when in doubt, do the 12-lead ECG. So this is very, very important and so foundational. I know that some of the facilities that we've worked with, they have really made a strategy to get this done, because you have to take that patient, immediately be able to take them to a place, a private location where you can conduct this. The second bullet point there, the ED staff needs to be trained to perform the ECG. We're not in a situation with many small facilities, particularly critical access, where we have a specialized individual who can do the ECG. So we do need to have the personnel trained. You need to have the equipment in the emergency department. Having worked with both Kansas and Nebraska, it was not unusual for the ECG machine to be used both on the inpatient wing, and you can call it a wing, but it's right there by the emergency department, and in the emergency department. So there was oftentimes a searching for the equipment. I actually even found a facility where, because it kept being lost, they locked it up. So these are all strategies that you need to think about when you're have the goal for your arrival to 10-minute ECG. I would mention to the larger facilities that oftentimes we found in the states I worked in before that a larger facility will upgrade their ECG equipment, and that is an opportunity to be able to perhaps have the smaller facilities get an additional ECG machine. So when you see that happening, if you're transitioning, think about your referring hospitals and whether or not that's something you could support them in that way. So it's important to have your ECG, and then really you need to know how quickly are we doing this. I know I have a few ladies that prided themselves in getting this done in 7 minutes. All right, so we have the ECG, we've established, oh, and important, I need to go back there, very important, it's in the middle here. You show all ECGs immediately to a physician, or if you have a PA or whoever happens to be running your emergency department, immediately for an initial interpretation. Don't go with your gut feel. Make sure you show that to a physician. Make sure you've set up a process that even though they might be seeing another patient, that you don't wait. You have them look at that ECG. All right, we have a thought that it's ST elevation. So now what we are looking at is 2 different Class 1 level of evidence B choices that you are looking at. The first one is that if you are not going to be able to get that patient first medical contact to device time, if that's going to be more than 120 minutes if you call somebody to transport them, then you are going to be going down the pathway of providing thrombolytics. And the goal, again, is to do that arrival to needle 30 minutes or less. However, if you're able to estimate that you can get that patient out and to the PCI center and they would be able to be treated there with no delay, still meeting the 120 minutes, then you would want to make those arrangements. So let's talk about the thrombolytics for a bit. All righty, well, we talked about that. Again, keep in mind that these are both Class 1 level of evidence B. So you're not picking a less effective method when you have good knowledge to know that you'll exceed the time frame to get to PCI, and you're choosing to do thrombolytics and then transport. So both are Class 1 level of evidence B. We talked about making sure that door to needle 30 minutes. And it will be important for you to have an efficient and simple rapid screening for thrombolytics. What you're seeing here, and I imagine you can't read that, but this is something that we have available. You can just ask us. We'll be glad to get this out to you. Of course, it's in the slide, but we can also provide it in different formats. This is information that either can be collected by your EMS as they are transporting them, which that's a great collaboration if you're able to contribute to their education and work with their medical director to do that. But what you're doing is really going through this and making sure, have they had a recent stroke? Have they had any previous type of hemorrhage? Do they have certain family histories? So that you are able to look through and be prepared with a quick checklist to make sure you've looked over any of the bleeding issues. Some folks have all of their thrombolytics. They have what a clot box or a toolkit, so that everything they would need to be able to do that is all in one place, and so that there isn't any delay because a lot of times in a small hospital, you're not going to do this very often, so you really need to be prepared so that you can rapidly administer the lytics. Okay, now, we talked about arrival in 30 minutes. I have seen some significant confusion because this is a lot of times isn't something you do on a regular basis to make sure we're getting the right thrombolytic. T&Case is the most commonly used lytic for STEMI. You can note that TPA or Activase is FDA approved for use in STEMI, but it is considered a second line or older generation medication. So for STEMI, T&K is the best, and if you recall, there used to be Retaplace, but that's something that's no longer available. So really work closely with your pharmacy consulting to make sure that you have the necessary lytics on hand, both for acute ischemic stroke as well as for ST elevation MI. It's important to do significant training on this. Don't hesitate to have the pharma representatives for these medications do the necessary training. That also have dosing, administration videos, and they have this for the different lytics. It has not been uncommon in my history to see a mixing up of the various lytics, and they do need to be administered in a different way. So we're talking about STEMIs here. So tenecteplase is the lytic to be used. All right, the tricky one, door in, door out. Some people like to say DIDO, less than 45 minutes. So we're really talking about 10 minutes to ECG. If lytics are indicated, door to needle, 30 minutes. If they are not, and you're trying to get them out the door, we want to have arrival to out the door in less than 45 minutes. So again, I talked about the importance of rapid ECG for walk-ins. You have a lot of walk-ins. They aren't going to call 911. That's just the culture of some of these areas. We'll continue to push it, and we want them to, but you need to have a process in place to identify and get that rapid ECG. If they come in on ambulance and they're suspicious that we're talking about a heart attack, keep them on the EMS stretcher and hold the ambulance until the 12 lead can be evaluated, because you could very quickly get them out the door. If your ambulance is not allowed to leave the county, or you have to always call a different transport service, that doesn't apply. Remember to call for your transport, whether that be air or ground. You should call for transport as soon as the STEMI is identified. Work with your regional transport systems. Normally they are fine being called off if it ends up not being a transfer, but it's very important to do that early. And then you want to notify the receiving hospital and send the patient. You do not have to finalize all of the paperwork. A lot of times we're getting significant delay in the transfer of our patients when we're trying to finish up the paperwork. So again, we're focusing on less than 45 minutes. Something that we did in a couple of my areas was we really worked on what we called the 1030 project, and our goal was that as a region, actually in that case it was as a state, that all of our small hospitals would work diligently toward the 10-minute ECG and what we selected as 30 that applied to door in, door out, and to the lytic time frame. It just kept it clean. The timeline is 45 minutes, but for cleanness, we just worked on a 1030 project, which was to try to really work on each of these elements. By participating in Get With the Guidelines coronary artery disease, you're going to be able to look patient by patient as how you're performing in these areas and be able then to dig down and look at doing improvements. If you keep a patient at your referring center, obviously, when you're aspirin arrival, if you're keeping them, then you're going to do aspirin. Oops, sorry, we got a typo there. Aspirin, beta blockers, statins, and your smoking cessation counseling. Again, all of this is recorded and kept track of in your Get With the Guidelines coronary artery disease registry. You're able to then look at that performance based on the day of the week. I know sometimes you may have physicians who are not permanent to you that are traveling physicians. You can also look at the discharge performance based on 5 physicians. So the tool will help you on these. By doing this, both in STEMI and in STEMI, you are eligible to be recognized by the American Heart Association for providing guideline-based treatment. And these volume requirements are very reasonable now. When we first started, we had a little higher numbers that were difficult. But for STEMI recognition, you just have to have an average of 2 STEMI records per quarter. And you have to meet the achievement score of 75% or greater on each of those STEMI measures that I talked about. In non-STEMI heart attacks, you again have to have an average of 2 in STEMI records into Get With the Guidelines CAD, and you must achieve those scores at 65% or 85%, depending on which category of measures they are. All right, and this year, 2018, a bronze is an award for a calendar quarter. I have met the guidelines for a calendar quarter. Silver means I have met that for 2 calendar quarters, and gold is you did it before and now you're doing at least 2 calendar quarters. So because this has come out late in the year, we are making it so that you do not now, November, have to go back and do all the year. You can actually just do 2 quarters. Here's the NSTEMI guidelines. These are very straightforward. You're going to have a lot more of these patients. And keep in mind, if you don't have enough volume on the STEMI side, you can still be recognized as a Mission Lifeline NSTEMI facility. So we're looking at the percentage of those patients who are referred to early outpatient cardiac rehab, so important, and the science indicates it's necessary. We're looking at the percentage of those patients that had a low ejection fraction. We're actually using that less than 40%, who were discharged with an ACE or an ARB. Also, those patients who are eligible for dual antiplatelet therapy, that they're discharged appropriately on that, and that's that 65% compliance measure. Then looking at those who had LV function evaluated, as well as the smoking cessation. So you say, I don't have enough of those ST elevation patients. We'll start to work on the patients that you do keep using Get With The Guidelines CAD. All right, we talked about this a little bit, but this year you can enter 1 quarter of data into Get With The Guidelines CAD. If you meet the volume criteria and the measure criteria, you'll be recognized right away in 2018. And then if you want to enter 2 quarters, you can actually increase your award level. So for most of you, you may be able to jump on the bandwagon there with as little as 1 quarter of data entered in. Why do it? Awards and recognition are important, especially in a smaller community that may think, I always have to go to the bigger town. They're making decisions that impact their care by not going to their local facility. By being recognized, we use U.S. News and World Report. We have an advertisement that includes all the recognized facilities. We also provide recognition press release, a whole ag kit that your hospital can use, and then, of course, all of our associated social media, you would be listed as a recognized facility. Actually, there may be those of you on the phone who receive Mission Lifeline awards. We are having our annual recognition ceremony at the upcoming Scientific Sessions, which is in Anaheim, California. So for those of you who haven't joined us, we want you to join us next year as a recognized Mission Lifeline facility. And regardless of your size, you can meet the guidelines and demonstrate to your community your high quality of care. And then a really exciting element of working with Get With The Guidelines CAD is that you also get a wonderful team across our entire country of consultation or field staff. Kristen Waller is the field staff for the state of Arkansas. She's also our expert as it relates to Get With The Guidelines, coronary artery disease, and Mission Lifeline. And she and I and all of our team, we work with our hospitals on a regular basis. You actually each have been assigned a territory director, regardless of the size of your facility. We are here to provide consultation at no charge to you. And so I'm going to turn it over now to Kristen to tell you a little bit more about how that works, some learning opportunities we have, as well as a little more about the tool. Kristen?
Hi. All right. This is Kristen, and I want to talk to you a little bit about the pricing and the registry. Okay, there we go. I was making sure I had control. Just some highlights on the pricing for entering 2017 data. Get With The Guidelines CAD is free. If you enroll for 2018 by November 1st, you will receive a $500 discount on the 2018 fees. Also, if you're a critical access hospital, there is a 50% discount for 2018. Here's the pricing for the early adopters that enroll by November 1st to enter data directly into Get With The Guidelines CAD. It's $2,750. If you're critical access, it would be half of that. If you use a vendor to enter, it's $2,500. And then there's also the option of participating in static quarterly reports where you enter the data, and then you will receive your report 3 months after the close of the quarter instead of actually being able to run real-time reports. But we do have that option available. And this is some of the differences in the 3 different ways to enter your data. There's the direct entry, the certified vendors, and then your static quarterly report. So if you see down there at the bottom with the static quarterly reports, you would use a vendor, but you would not be able to use to run real-time reports to look at your data. You would receive that report 3 months after the quarter closes. Here are some of the vendors that we are working with to become approved. So if you're already using one of these vendors for other modules, maybe Get With The Guidelines Stroke, you could check with them and see where they're at and being able to enter your data for you. If you log on to heart.org, you could actually, here's the website here, but if you Google Focus on Quality with the American Heart Association, it will pop up with all of our quality programs, our Get With The Guide programs, and you can click on Get With The Guidelines CAD, and it will have a place where you can enroll. Okay, so I want to point out a few helpful hints that would get you going with Get With The Guidelines CAD once you've signed up. This is our community page on the patient management tool, and you will see there's several different options there, but if you're participating in CAD, right there in the center it says Advanced Reporting. So if you click on that, there's a short video. It's probably 20-24 minutes, and it just explains how to run reports, how to filter reports, and then there's also right below it downloading, and it will show you how you were able to download your data into an Excel spreadsheet, and you can customize it for what your facility is looking for, what you want to report, and share it that way. Okay, so if you click on the first silhouette here, that's how you get started entering a patient into the registry. And over here we have a legend. We have a new patient. Down here, this little toolbox is for resources, and within that you're going to have several things to help you out, such as a blank abstraction form, coding instructions, the patient management tool user guide. So everything that you'll need as far as getting started, you can find here in your resources tab. But once you're ready to enter a patient, you click on the silhouette of the patient to get going. So once you're inside the registry or the patient management tool, anything that is bold is required for Get With The Guidelines, and anything with the little caret, the little arrow, is used for Mission Lifeline measures. So you'll also see the circle with a C, and that's how you clear, like if you've selected an option and you don't want that or to click another, you just click on that button to clear it out. So you'll see that there's a place that you can enter the physician provider. That will come in handy whenever you want to run reports and filter it by physician. You could do it by individual physicians, or you can even compare physicians if that was what you would like to do at your facility. Okay, my computer is running slow. Let me see here. Next on the admissions tab, on the pre-hospitalization tab. Can someone tell me if that has switched over? It's kind of frozen in between the two screens on my computer. But you should be seeing a a pre-hospital tab, and within that, up circled at the top is, okay, I see it's clicked over now. Okay. The EMS agency is circled there, so if you have several agencies that are bringing patients to your facility, you can track them there. You just click which one brought the patient, and then later on you can go back and filter it by which agency brought it in, and that way you can give report back to them as well. And this little button right here is, you click on it and it will set the date for all of these sections for you, so you don't have to keep putting in the same date, because the first medical contact with EMS and dispatch and depart scene and arrival, those are all going to have the same date unless it's somewhere around midnight, so you wouldn't be able to use the button there. But for most cases, you would be able to click on that and save yourself some time and just have to go back and plug in the hour and the minutes. And for our referral centers, this section probably would not apply. You would be transferring them out instead of someone transferring them in. Okay, and as you're going through and entering your data, there's a little tab just to the right of the page, and it says errors, and you can keep it minimized, or you can open it up, and it will let you know as you go. Maybe you skipped a date or you left something blank, and it will just alert you to let you know that before you even switch to the next tab that you're missing something or something's not adding up, and you can fix it right then. So if you give thrombolytics, there's a section here. If you're going to give the thrombolytics before you send them, you just click that they are a reperfusion candidate. And then if for some reason you can't give them or there was a delay, you need to click Y. So if you click no for thrombolytics and no for PCI, it's going to make you fall out of the measures unless you give a reason why. So just remember that. If you don't give them, click Y. And here's your reason. So you didn't do PCI because thrombolytics were administered, or you didn't give lytics because you're going to send them on their way to the referral center and try to meet that goal of door in, door out to balloon within 120 minutes. And here's the discharge tab. So if you're keeping the patient, this is something that you would track. Whether or not they were given their ACE or ARB on discharge or aspirin on discharge, several things there. So if you're sending them on their way to the receiving center, then we're really looking at, did you get the EKG within 10 minutes? If you were needing to give lytics, did you give those within 30? Or if not, if you're transferring them for door in, door out to balloon, then were you able to transfer them out within arrival to transfer within 45 minutes? But if you do keep them, then you need to make sure that the proper medications were prescribed at discharge. There's also optional field tabs. If there's something that your hospital is wanting to track, then those can be site-specific tracking options. All right, so you've gone through and you've entered your patient, you've done all the tabs, and then you come over to the Measures tab. And before you can even submit this patient, you have the option to calculate your measures. So this particular patient was brought in. They did receive their EKG within 10 minutes of arrival, and they also received their thrombolytics within 30 minutes. So they're both green. Had we fallen out, there would be a red. It would be red. And so you could go right then and check. You could click on any of those tabs above and try to figure out maybe you just missed something, or you need to go back through the chart, or maybe you really did fall out of the measure. But you would know before you even submit the chart whether or not that you met the measures. So the grayed out measures would be ones that don't apply to you. So this patient right here was given thrombolytics, and then they were transferred out. They weren't kept, so the discharge medications did not apply, and the primary PCI did not apply because lytics were given. So you do have that option of running real-time measures before you submit the patient. You also have the option of printing the report, so all of the information, the date and times and that you entered will print out on a clean copy that you can share at your meetings if you have a chest pain meeting, or maybe with your quality director or your ER director. And it's just it looks similar to the abstraction form that you might be handwritten, but it will print out a copy that is printed, look a little look clean. Okay, so back to the community page where CAD, you see the double silhouette. So this is going to be all of your patients there. You just click on that if you want to look at all of the patients that you have. And within it will list every patient by date. You can click on the date to open up that patient within the patient management tool. There's the option to delete the patient. Maybe you entered them and then realized that they didn't have the correct diagnosis coded, or for whatever reason, if you need to delete the patient, you have the option to do that. Or if you entered their patient ID wrong, you can change that right here on that page as well. The next tab is reports. You select this one and you can run reports, real-time reports. You click on configurable measures reports. You're also able to run audit reports, and you can see who has been running reports of your data within your facility. There are predefined measures reports as well. So when you go to run a real-time report, you can select it by month, by quarter. You just filter it however it is that you're wanting to do that. And then you select your, let me go back one. You select the measure. You can run it by STEMI Referral Center, and it will have all of your measures there that you want to look at. You can do it as a bar chart, a line graph. You can filter it by patient if that's what you're wanting to do. If you're wanting to see your patients that are falling out, you can select that there. There is an option to look at just your hospital, or maybe the hospitals in your region or your state. And when you build reports, you can save them within the patient management tool. You can save them to your computer, or you can save them within the patient management tool as well. And here are some of the filters that we have when you want to compare. Maybe you want to filter it down to the weekend. You do great during the week, and then the weekends you struggle a little bit, so you would compare Saturday and Sunday. Maybe it's a certain age range. You're missing out on the younger ones that are starting to have heart attacks. We're seeing a trend there where the heart attacks are happening younger and younger, so maybe we're not acting as fast on the younger population, so we can select that and check those. You can compare gender. Maybe you want to filter it down to the ones that arrive by walk-in or by ambulance, or physician. If you want to look at physicians, you can look at them one at a time, or you can compare them. However many that you have, you can compare them. So this is a real-time report, and this is looking at the different quarters. And you'll notice that not all of the bar graphs are there, so you just didn't have patients that applied to those particular measures during that quarter. But there's a color for each one, real easy to understand. And then it breaks it down, too, to let you know where you're at, like EKG within 10 minutes of arrival, you're at 100%. You didn't have a lot of volume, but you were at 100%. And these are the measures that would apply to a referral center that you're transferring the patient out. So you've got your EKG within 10 minutes, you've got your arrival to thrombolytics within 30 minutes, and then also your arrival to transfer to PCI center within 45 minutes. your door in, door out. And then I talked about patient drill down. You can do it by particular measure. This one just happens to be for patients. Did they receive an ACE or an ARB on discharge for a low EF? So this probably would not apply to most referral centers because you're going to transfer them out. But I just wanted to show you that there's a way to filter by particular measures. You may just want to look at your EKG to arrival or your door in, door out, and you'd be able to do that, and you'd see if they were included or excluded. And if you wanted to check why, you just click on the ID, and it will open up that patient record for you. And then our regional reports. We require that 6 hospitals participate in a regional report. If you don't have that many in your region and all of the hospitals in your region are agreeing to participate, then we can probably do one with less hospitals. But this is just a sample of what it would look like. And you'll see down in the blue would be your EMS first medical contact till the time that they got to the ER door. And the kind of pink color there would be your ER time. And then the green would be from the ER to the cath lab to the PCI. And I already talked about the little resources tab. You just click on that, and within it you can get blank abstraction forms or your coding instructions or patient management tool user guide. So there's several resources there to help you out. And like Cherie said, you do have QSI consultation staff that's in your area and wanting to help you out. If you have any questions, you can always reach out to them. Okay, so I talked about the downloads video. That's approximately 14 minutes. It's found on that community page at the very beginning. You can create this however you want it. For this one, I just selected, I wanted the patient ID, their date of birth, their arrival date and time, EMS first medical contact, when EMS was dispatched, they arrived on the scene, they departed, did they notify before they arrived at the destination. And then down here it's just got some more times. This has cath lab times. So this may not apply to your hospital, but you can create this however you want it to, and it's in a nice spreadsheet. So I know some people will enter, some abstractors will enter into a registry, and then they have to go and create their own Excel spreadsheet to keep up with for their hospital. So once you enter it into the registry, you are able to just download it, and you don't have to worry about keeping up with a separate spreadsheet. Just customize it to however you need it to look. There's also an option where you could do for discharges if you're looking at did they get their medications on discharge. And then that one may be specifically for the cardiologist or your hospitalist, whoever is discharging that patient. You could share that with them, maybe even case management. And now we can open it up for questions. If you have any questions, just hit *6 to come off mute. And when you're done asking your question, you can hit *6 again to go back on mute.
Hi, so we do have one question came into the Q&A section. If we already are ACC Cycle V accredited, is this separate from Mission Lifeline since they are both run by AHA? How does this work with what we are already doing with SCPC/ACC?
Lana, you want to take that one?
Yeah, I can take this one. Can you hear me?
Yes, we can.
Great. So the American Heart Association and the leadership from ACC and NCDR met and determined that the Gwtg guideline coronary artery disease will will be an approved platform for chest pain center accreditation. So a formal announcement is it's forthcoming, but we do have word, and we're given permission to go ahead and let people know. As I think Kristen or Cherie mentioned, the chest pain center data element will be added to the Get With The Guideline CAD tool. We do have a number of them in there already. You can enter your chest pain patient information, and you can use the optional fields, but we're working with NCDR to make sure that the full measure set is added to the Get With The Guideline coronary artery disease tool, and that is scheduled to happen in the February-March time frame if everything goes as planned. So, we are continuing to work closely with our American College of Cardiology partners in the accreditation space. We have a number of joint accreditations and are, what we call data agnostic in terms of utilizing different data sources so that hospitals can choose which registry they want to participate in.
It's Cherie. I might just add, though, related to your Mission Lifeline recognition, the only data platform that you can use to keep or get Mission Lifeline recognition, so the little icons I've showed, is Get With The Guidelines coronary artery disease. In the past, you got that recognition using NCDR Action Registry. So if you are a Mission Lifeline recognized facility now, it is necessary for you to make that change, and you can work with your territory director to talk about how to get your historic data out of there. You can run them both and still maintain your Mission Lifeline recognition or gain recognition through Get With The Guidelines CAD. Other questions?
Remember to ask questions. You can unmute your line by pressing *6 or type in the Q&A section of WebEx.
While we're waiting for those questions to come in, Cherie again, for those of you who are on the phone who are receiving centers, I encourage you to reach out to your territory director and talk about some platforms whereby we can give you assistance in communicating your requirements as you are referring patients, getting patients referred in. We're willing to assist in that process. Sometimes it's difficult for the larger facilities to have enough manpower to get out to your referring hospitals. So we would love to partner with you to visit with the whole system, EMS, referring and receiving, and be able to communicate all together what the regional plan is. *6 to ask a question.
We have one more. What is the length of time that the Mission Lifeline certification active once received by a hospital?
So if the question is how long the accreditation is good for or how long the cycle is good for, it's 3 years. We repeat the question, make sure that we're answering that correctly.
Sure. So what is the length of time that the Mission Lifeline certification active once received by a hospital?
Yeah, 3 years, 3-year cycle.
Kristen, any closing comments you'd like to make?
Just that, I worked at a receiving center, and so we work closely with EMS, and we're in the process of working closely with referral centers, and I think this is just an excellent opportunity to bring everybody on board, everybody to have the same goal, but their own goals, where they're working towards things. The referral center is working towards the EKG, the lytics, and getting them out as quickly. And so they're able to understand that, you don't have to completely treat this patient. Just do the basic things that need to be done and get them out the door to the cath lab. And so I think it just opens up the lines of communication between everybody within your volunteer EMS, within your paramedics, your referral centers, and the PCI center. I think it's just a great way to open the door between everybody.
Well, and to make that communication simple, because we all want to be able to send out reports to the referring centers and to our EMS so that we can continue that education process. But in the past, it's really been difficult. And by simplifying the data that's collected and making these reports real time so that you don't have to wait to the end of the quarter, at the end of every week, you can send out your reports to your referral hospitals, to your receiving hospitals. And for referral hospitals, you can send it to your receiving hospitals to show them how you're doing, kind of proactively instead of waiting for them. So I think the easy reporting with real time, if you put it in, you can report on it. And that is a little different than we've had in the past. One more chance for some questions. We're coming to the end of our time. So anything online, Audrey?
Yes, so we did have another question. Will this PowerPoint be available to us after the webinar for us to review later? And the answer is yes. All slides and handouts will be sent to attendees within a week of the call.
And a couple quick reminders, because we have a deadline coming up. The folks who sign up by November 1st, which I realize is very soon, but we will, if you've been using Action Registry, which probably some of the smaller ones haven't, but those larger facilities, if you've been using the Action Registry and you want to continue, but you want your historical data into CAD, you need to sign up by November 1st, and we will help you at no additional charge get that historic data into CAD so you can run those side by side. And that also allows you to take advantage, as Kristen told us, of the $500 discount for next year. There's really no risk in seeing how this works because there's not a cost for 2017. But I think you'll see when you get to have your hands on it that it's a really valuable tool and will save you a lot of time. And we want to thank you for joining us for this webinar. And you've got our emails there. So if you're not sure who to talk to in your territory, just pop Kristen or I an email, and we will get you lined up with your territory director. And as always, we appreciate your support for the American Heart Association, American Stroke Association, and are looking forward to working more closely with you. Thanks a lot. Audrey, any closing words?
No, that concludes our last webinar. All slides and handouts will be sent to attendees within a week of the call. Thank you to everyone who has been following along with us. Please visit www.heart.org/SWA Quality for more information. Thank you all.
Thanks, everybody.